Hello, everybody. My name's David Gilbert, and I'm a professor of medicine at the Oregon Health and Science University in Portland, Oregon, and I'm based at a university-affiliated community teaching hospital called Providence Portland Medical Center. And I'm excited to share some of our work on enhanced pathogen detection in the management of septic pneumonia patients. These are my disclosures. I've been off and on a consultant for the bioMérieux company, and a lot of the data that I'm going to present today is a result of a research grant from Biofire Diagnostics. And our focus is community-acquired pneumonia, particularly community-acquired pneumonia of sufficient severity to require hospitalization. There's over 1 million such patients per year in the United States. There's a large number of potential viral and bacterial etiologic pathogens involved, plus a huge variety of concomitant non-infectious diseases that complicate the diagnosis and management. The status of diagnostics for community-acquired pneumonia has been summarized as the following quote, that standard diagnostic methods are too slow and insensitive to guide early decisions concerning treatment and isolation. And the basic assumption is that if we could detect potential microbial etiologies early, that could guide and focus antimicrobial therapy. We're better to know what's there than what's not there. That should lead to, if we were able to do such, better patient outcomes, less risk of promoting resistance to antimicrobials. Fewer antimicrobials means fewer serious adverse effects like allergy and Clostridium difficile, less pressure on selection of antibiotic resistant strains of bacteria, and more cost-efficient care. Just a quick history of what has been recommended for the microbial diagnostic testing of immunocompetent patients hospitalized with community-acquired pneumonia. Until the last 10 years, diagnostics were generally limited to cultures of sputum and blood, urine antigens for Legionella and the pneumococcus, and probes for influenza and sometimes respiratory syncytial virus. That package identified potential pathogens in roughly 20% of the patients. It was recognized that there was a need to do better in pathogen detection, and that stimulated the EPIC study. EPIC stands for Etiology of Pneumonia in the Community Surveillance Study. Excuse me. The goal of the EPIC study was to determine the incidence and microbial etiology of community-acquired pneumonia in immunocompetent adults using what was then state-of-the-art diagnostic modalities. So enrolled patients had blood cultures collected, and that happened in 91% of the enrolled patients. Urine antigens performed in 85% of the enrolled patients. Sputum or sputum equivalent like endotracheal aspirates were gathered in 41%, less than half of the patients. Further, most of those sputum were collected after the first or second dose of empiric antibacterial therapy. To assess the viruses detected as to whether they were colonizing or invading, acute and convalescent sera were assayed, and that occurred in 37% of the patients. The study detected potential pathogens overall in only 853 of 2,320 enrolled evaluated patients, or 38%, a disappointingly small number. It broke down to detecting one or more viruses in 23%, one or more bacteria in 11%, and the combination of virus and bacteria in 3%. So you can already guess why the low frequency of pathogen detection. First of all, there was the inability to get sputum in over half of the patients. Both sputum and blood cultures would be affected by prior administration of the empiric antibiotics. And quite frankly, the molecular diagnostic era had not arrived, so we had less than the most sensitive tests, such as PCR. And that led to that conclusion that we need new, rapid, sensitive diagnostic tests to identify the potential etiologies in patients admitted with pneumonia. So the next, perhaps seminal statement is the practice guideline from the Infectious Disease Society of America and the American Thoracic Society on recommended diagnostics for inpatients. And this was published not that long ago in 2019. And again, it's very basic: sputum, gram stain and culture, blood cultures if the pneumonia was severe, that is, patients in shock or requiring mechanical ventilation, urine antigens, again, if severe, and PCR was limited to influenza on a seasonal basis. One would not expect a dramatic increase in pathogen detection with this limited diagnostic panel, if you will. And that's about the time that we at Providence Portland Medical Center got interested, and we were stimulated by the then available and still available Biofire Respiratory Film Array PCR panel done on nasopharyngeal swabs. That panel can detect 8 viral and 2 atypical pneumonia targets. In addition, we had a commercial product for nasal PCR for detection of Staph aureus in the nares, nasal PCR for strep pneumoniae, that was a laboratory-generated PCR. And then we did the urine antigens, the culture of sputum and blood, and then to help with assessment of detected pathogens, we collected 2 procalcitonin levels within the first few hours of admission to the hospital. And our detection rate was much higher than the EPIC study. We detected a potential pathogen in 73% of 127 evaluable patients. We detected only a viral pathogen in 28%, only a bacterial pathogen in 45%, and both bacterial and viral pathogens in 27%. And those results were published in 2016. But we felt we still could do better, and we proposed comparing the Providence Bundle detection rate, if you will, with the then investigational Biofire Pneumonia Film Array panel. We were motivated because that panel, the pneumonia panel, had the potential to replace most of the bundle that I just described. It added PCR detection of 15 common bacterial pathogens not detected by the respiratory film array. And it added detection of 8 antibiotic resistance genes, which helps fine-tune the antimicrobial therapy of the individual patient. It took 1.5 years for the study that I'm about to summarize for you, and conveniently the results were just published in Diagnostic Microbiology and Infectious Disease in the March issue. So just to make sure that we're clear, this slide compares the targets with the respiratory panel versus the pneumonia panel. So the respiratory panel done on nasopharyngeal swab and the pneumonia panel done on sputum or sputum equivalent probes for the same 8 viral targets. As far as atypical bacteria, the respiratory panel probes for chlamydia and mycoplasma, whereas the pneumonia panel adds Legionella, so we wouldn't have to do a Legionella urine antigen. And then the main attraction, or a main attraction, was the probe for 15 common pathogens that cause community-acquired pneumonia, which include non-fermentive gram-negative bacilli like Acinetobacter and Pseudomonas aeruginosa, other Enterobacteriaceae, and gram-positives to include staph, group B strep, group A strep, and Streptococcus pneumoniae. So an enhanced target inventory, if you will. So the question was, could we change our diagnostic approach to patients admitted with community-acquired pneumonia to including the sputum and blood cultures, and then just do the Biofire PCR panel on sputum, and using each patient as their own control, compare the detection yield with that multi-test bundle. Again, we still are using the blood and sputum cultures, the nasopharyngeal swab instead of the sputum swab, and the extra PCRs for Staph aureus, pneumococcus, and urine antigens. And then, as mentioned, we did procalcitonin twice in the course of the first few hours of hospitalization to help with adjudication. So over a year and a half, we had 585 patients who presented to the emergency department and were diagnosed by the ED physicians as having community-acquired pneumonia of sufficient intensity and severity to require hospitalization. Out of that 585, more careful chart reviews indicated that we had to exclude 311, 159, because they turned out on closer evaluation to have a diagnosis other than community-acquired pneumonia, or 139 were unable to produce sputum, or we failed to get the full inventory of test procedures in 13 patients. So we ended up with an evaluable population of 274 patients. The charts were reviewed, and in the end, all the patients with detected pathogens were adjudicated by a trio of the investigative panel of investigators to determine whether we believe the pathogen, whether the pathogen was colonizing or invading. So these were pretty sick people. This is the demographics, selected demographics of 274 of the evaluable patients. They're older, as you might expect. There's a lot of comorbidities in terms of alcoholism, cerebrovascular disease, chronic liver disease, heart failure, COPD, diabetes, illicit drug use, malignancy, obesity, and 4% had renal insufficiency. You can tell from the pneumonia severity index that over 50% were class 4 or 5, which is the more severe categories, as you know, of community-acquired pneumonia, and only 17% were class 1 or 2. So to cut to the chase and then go into the details, this is the detection result by category of potential pathogens. We detected one or more potential pathogen in 95% of the 274 evaluable patients. We only detected a virus, one or more viruses, in 31 or 11%. We detected only a potential bacterial pathogen in 87 or nearly 32%. And a striking percentage had virus, potential virus, and potential bacterial pathogen, 52.2%. And as mentioned, it was only in 4.7% where no potential pathogen was detected. So if we break it down to bacteria versus virus, and the bar graph shows the number of patients with detection of the pathogens indicated on the horizontal axis, the light blue or gray is detection with the multi-test bundle, and the dark blue is detection with the Biofire Pneumonia panel. With the pneumococcus, the dark blue pneumonia panel detected almost as many patients as the bundle, which includes culture and the PCR and the urine antigen. Look at the striking difference with Haemophilus and Moraxella catarrhalis, where the pneumonia film array dramatically detected many, many more patients than standard sputum culture. And we wonder if that's because of the inhibitory effect of the antibiotics that were given 1 or 2 doses, or just overgrowth on the sputum culture plate so that the lab folks couldn't see the Haemophilus or the Moraxella. In contrast, Staph aureus was interesting in that the PCR on the nose swab was more sensitive than the PCR on the sputum or sputum equivalent for the presence of Staph aureus. The other streptococci, Strep A galactea group B, Strep pyogenes group A, the PCR on the pneumonia panel detected more patients with such pathogens. Same thing was true with the Enterobacteriaceae, and for the non-fermenters, the numbers were really too small to assess. This just demonstrates again how sensitive the Biofire Pneumonia panel was at detecting the pneumococcus compared to other methodologies, the nasal PCR, the urine antigen, sputum culture, and blood culture. We only had 10 patients out of the 274 with positive blood cultures. The viruses were very dramatic in favor of the sputum probe with the Biofire Pneumonia panel. In virtually every virus assessed, the pneumonia panel had a higher detection rate than the nasopharyngeal swab. Remember, we did the nasopharyngeal swab in the bundle, and we did the pneumonia on sputum. And for adenovirus, coronavirus, human metapneumovirus, influenza, parainfluenza, RSV, and rhinovirus, the detection yield with the Biofire Film Array pneumonia panel was statistically significantly better. And our results are validated, or we validated the work of others at enhanced pathogen detection by the Biofire Pneumonia panel. And I'm just summarized 6 other published studies, and you'll be happy to know we're not going to go through all of them. The pneumonia panel detected viral and/or bacterial potential pathogens in between, depending on which study you want to quote, between 49 and 73%. If we look at just the detection of bacterial pathogens that were detected by the Biofire Pneumonia panel and not detected by culture, it was quite significant, and we'll just quote the Murphy study because that's the largest number of patients evaluated. In 875 of 1,764 patients' sputa, the pathogen, potential bacterial pathogen, was detected with the pneumonia panel, where it was missed by routine culture and sensitivity. So you can quickly discern that the results of the panel can influence patient care in so many different ways. Detection of influenza, whether it's on the respiratory swab, the nasopharyngeal swab for the respiratory panel, or the pneumonia panel, leads to early therapy, if that's pertinent, with oseltamivir and isolation. Detection of MRSA leads to an adjustment in isolation care, as well as empiric antibiotic therapy. And then we'll come back to the detection of the resistance genes that mark the production of extended spectrum beta-lactamase or carbapentamases, which obviously also determine your empiric antibiotic therapy while you're awaiting sensitivity results. So the good news is that we have the rapid detection of common potential viral and bacterial pathogens. That's good. We would like to know what's there rather than operating in the dark. The bad news is, are all of those detected pathogens colonizing and not of consequence, or are they invading the host? This has been called the elephant in the room of molecular diagnostics. So there had been a wide variety of attempts to separate colonization versus invasion of detected pathogens. They're all listed here: the clinical picture, the white count and differential, the number of white cells on gram stain of sputum, semi-quantitation of the bacterial load by streaking the sputum on agar plates. I'll show you an example. The pneumonia panel actually calculates the bacterial load by the number of PCR threshold cycles needed for detection. The fewer number of threshold cycles, the higher the bacterial load. Unfortunately, these approaches lack adequate specificity and sensitivity, and so folks have turned to biomarkers with the logic that if the C-reactive protein or serum procalcitonin levels are increased, that would be consistent with invasion of the host by the detected bacterial pathogen, and the host would mount an innate immune response that includes procalcitonin. Just to remind you, standard technique of determining bacterial load is streaking the blood agar plate, trying to, by gradual dilution, inoculate all four quadrants of the plate, giving you a 1+, 2+, 3+, 4+ report from the laboratory. The purulent sputum, in addition to having lots of bacteria on the gram stain, also has a plethora of neutrophils. Does the bacterial load help adjudicate colonization versus invasion? I don't have time to go into it, but I'll call your attention to this reference in Open Forum Infectious Disease, where there is a documentation by the investigators of high levels of potential pathogens as registered by the number of CT thresholds that were identified, but they did such results of bacterial load still don't tell you whether the pathogen is invading or not. We need evidence that the innate immune system is activated, which I have to show this slide because it's so unique. These were medical student volunteers that were inoculated with low concentrations of endotoxin or lipopolysaccharide, and then biomarkers of the innate immune system measured over the next several hours. And you can see that even before the volunteers started to show symptoms of chills, rigors, fever at 4 or 5 hours, we'd already had an elevated interleukin-6, tumor necrosis factor, and interleukin-10. Right about the 4 to 6 hour mark, procalcitonin elevations were noted, and a few hours later, elevations in C-reactive protein. Just to remind you about some of the key features of procalcitonin as a biomarker of bacterial infection, there is robust procalcitonin transcription by all tissues and organs tested to date, not just neutrophils and macrophages. The procalcitonin levels rapidly increase and rapidly fall, such that one has, if you have normal renal function, a 24-hour half-life of the serum procalcitonin level helping you judge source control when you're in the depths of evaluating and managing patients. We know that there's no or minimal increases of procalcitonin in pure viral infections. The negative predictive value for invasive bacterial infection with a normal procalcitonin is 95%. Another nicety in clinical management is that procalcitonin synthesis is not influenced by concomitant steroids or non-steroidal anti-inflammatory drugs, and procalcitonin levels do not increase in patients with many rheumatologic diseases like giant cell arteritis, SLE, and even gout. If we compare those facts with C-reactive protein, besides the difference in time to detection, the main difference is the increase with viral infection that occurs with C-reactive protein in the absence of increase that is characteristic of procalcitonin. And then those collagen vascular diseases also show a difference. C-reactive protein levels are elevated in patients with lupus and rheumatoid arthritis and giant cell arteritis, but they're not increased in, procalcitonin does not increase in the presence of those inflammatory entities. So overall, there's 4 ways that serum procalcitonin levels can assist in the management of the septic patient. Prognosis, which is a package insert, part of the approval of procalcitonin by the FDA. We primarily in this presentation are going to use procalcitonin as an adjudicator to separate colonization versus invasion by potential bacterial pathogens. As just mentioned, a rapid fall in procalcitonin level is consistent with source control, and the fall in procalcitonin levels can help guide duration of antibacterial therapy. Detection of candidate bacteria associated with a compatible pneumonia illness and an elevated procalcitonin level was judged in our study as compatible with an immune response to invasion by the detected bacteria. Detection of a potential viral pathogen in the absence of bacteria and with low procalcitonin level was judged compatible with inhibition of procalcitonin by virus stimulation of interferons, endogenous interferons. That's a normal host response to invasive viral pathogens is production of interferons. However, with dual invasion of bacteria and virus, the interferon blockade fails and procalcitonin levels rise. So all of this by way of introduction, how did it shake out with our 274 evaluable patients? We have 4 buckets. This shows the procalcitonin level on the vertical axis and the 4 buckets on the horizontal axis, and the red line is the cutoff of significant elevation of procalcitonin to 0.25 nanograms per ml or greater, and normal or not significant procalcitonin concentrations are considered by most investigators as less than 0.25 nanograms per ml. So in each category, we've got a number of patients who have a potential pathogen, a bacteria, virus, or the combination thereof with normal procalcitonins. And then we have those with elevated procalcitonins. And we're going to show you how we adjudicated that in each of those 4 categories. Just for emphasis, an elevated procalcitonin level indicates an active innate immune response. A low procalcitonin in the serum level indicates the likelihood of invasion by bacteria is 5% or less. So I can't emphasize enough the import and the usefulness of this negative predictive value of 95%. Such that we want absolute proof. So the National Institutes of Health has a study group called the Antibiotic Resistance Leadership Group. And they designed a prospective study. Patients with lower respiratory tract infection and low procalcitonin levels were prospectively randomized in a double-blind fashion to either placebo or azithromycin. Enrollment started in 2017, and enrollment ceased in 12/20/20 due to the COVID-19 pandemic. So we have no results. This is proof of concept, and hopefully that study will resume once the pandemic is under control. So how did we adjudicate our detected pathogens, our quotes expert panel? If the patient in question had a detected respiratory virus, influenza, for example, and the procalcitonin was less than 0.25, C-reactive protein may or may not be elevated, but they have a low procalcitonin level, that was adjudicated as compatible with a pure viral infection. The report would indicate no clear need, no need for any empiric antibiotic therapy. If the lab detected potential bacteria, or sometimes more than one potential bacterial pathogen, and the procalcitonin level was less than 0.25, that was judged as consistent with, yes, a pathogen is there, but it's only colonizing. If the procalcitonin was above 0.25, we considered that consistent with invasive bacterial infection. We have two more categories. What if we detected both a potential bacterial and viral pathogen? The procalcitonin is less than 0.25. That suggests it's the virus that's infecting, no activation of innate immunity, so the bacteria is colonizing. If the procalcitonin is elevated along with the virus, so influenza and Staph aureus are both present, we would interpret that as viral infection due to influenza and secondary bacterial infection due to Staph aureus. What if there's no virus or bacteria detected and the procalcitonin is less than 0.25? I suppose there could be an undetected virus there for which there was no probe in the pneumonia panel, or the syndrome is a non-infectious pneumonitis, mimicking community-acquired pneumonia. If the procalcitonin is greater than 0.25, but we didn't detect any bacteria, it's maybe because we didn't have a probe for the bacteria that was involved, and of course there could be an undetected virus as well. So this is just to remind you what's in the Biofire Pneumonia panel. So there's the 15 bacterial targets, or typical bacterial targets, 3 atypical targets, 8 viruses, and then the antimicrobial resistance genes. So when the laboratory director contemplates, this must be expensive, what am I to do? We asked that question, and based on 2018 data, put together some back of the napkin numbers. If we did the multi-test bundle, then the patient can't produce any sputum, so we have to do the multi-test bundle. We're going to therefore do the urine antigens, the nasal swabs to include the nasopharyngeal respiratory panel. We're going to do sputum culture and sensitivity, blood cultures, tech time, and procalcitonin charge, overhead charge. and we come up with $400 per patient, if you will. These are cost, not billing, but the actual estimated cost. If instead the patient's able to produce a sputum, we can use the Biofire Pneumonia panel, so there's no need for the urine antigens, no need for the nasal swabs, and hence less cost, or that would represent cost saving. We've got to pay for the pneumonia panel, and then we have the rest of the items in common, and it actually comes out for a few dollars less than the bundle. But we don't want to have the silo mentality. We want to think outside of the clinical laboratory, and I'll just refer you to this recent paper entitled "The Cost Impact of Procalcitonin-Guided Antibiotic Stewardship versus Usual Care for Hospitalized Patients with Suspected Sepsis or Lower Respiratory Tract Infections in the United States." This was a health economic model analysis. And for reasons of time, I can't go into it, but I can tell you that it factors in the impact of detection of pathogens, such as less antibiotic cost, less isolation cost, fewer adverse effects since we're using less antibiotics, shorter duration of therapy, faster return to health, and productive work life. It's quite an impressive number when you get to all of those out-of-the-box considerations. So how does Biofire Pneumonia Panel and procalcitonin data influence empiric patient care? So now we're pivoting into the stewardship realm. Separation of pure viral versus bacterial infection allows for cessation of empiric antibacterial therapy for pure viral illness, allows for early initiation of anti-influenza therapy, allows for isolation of virally infected patients, and then depending on the presence or absence of those resistance genes, helps guide stewardship efforts in focusing the antimicrobial therapy. Like all studies, we have limitations. We need sputum or a sputum equivalent for the pneumonia panel. Plus, we still need to try and culture a pathogen because we need the in vitro susceptibility results. In order to optimize the stewardship potential, we need the results of the procalcitonin and the Biofire panels 24/7 in order to maximize the influence of these modalities. We have to remember that the PCR panels only detect the targeted pathogens. So we are doing better, but we're not detecting all potential viral or bacterial pathogens. Ours was not an epidemiologic study. We didn't do sequential serologies to prove viral infection. But in distinction to children, in adults, it's rare for adults to carry viruses for very long. So usually if the virus is there, it is considered a potential pathogen. We did not document the impact of diagnostics on antibiotic stewardship, as I just mentioned, escalation, de-escalation, duration of antibiotics, adverse effects, and patient isolation considerations. So a pathogen is detected. A pathogen is detected in a community-acquired pneumonia patient admitted to the hospital, and in this case to the ICU. I indicate the ICU because for sure we would do blood cultures. And then we need sputum, whether it's expectorated sputum or endotracheal aspirate sputum. And so we can do the Biofire Pneumonia panel and a couple procalcitonins, and that's our diagnostic workup: blood cultures, sputum culture, and the Biofire Pneumonia panel. The patient's unable to produce sputum in backup, if you will, we still have that multi-test bundle, and you've heard the elements now several times, but it includes the nasopharyngeal respiratory PCR panel. Well, so the fruit of the month is procalcitonin in the panels that PCR panels, but nothing stays the same for very long. Metagenomics, which, excuse me, metagenomics, which is capable of detecting all microbial DNA as well as human DNA that's in the specimen, is evolving quickly, such that there are now at least 3 commercial sources for metagenomic sampling of body fluids, which includes airway secretions. Procalcitonin is a valuable asset, but coming along are host gene expression signatures, a couple of citations. The gene signature data is impressive at separating pure viral from pure bacterial infection. It still is problematic if there's a mixture of virus and bacterial pathogens. So if all of this fails, there's one last resort. You can go to Star Trek, and Dr. Bones has his magic machines where within seconds he can make specific diagnosis and recommend specific management. And with that, I'll show you a picture of Mount Hood where I live and invite your questions. Thank you for listening.